Welcome back to the deep dive. Today, we are not just cracking open a book, we are effectively dismantling a fortress of medical knowledge. We are tackling a true heavy hitter, Baily and Love's Short Practice of Surgery, specifically the 28th edition.
And when you say heavy hitter, you mean that quite literally. If you dropped this physical text on your foot, you would almost certainly need to consult the orthopedic section immediately after.
So yeah. But today, we are skipping the bones mostly and zooming in on Chapter 48, Cranial Neurosurgery.
It's a beast of a chapter.
It is a massive chapter, and I know what some of you listening might be thinking. Neurosurgery, that sounds terrifyingly complex, and, well, it is.
It is. There's no getting around that.
But our mission for this deep dive is very specific. We're going to turn this dense academic material into a ready reckoner.
I love that term. Think of this as your audio revision companion. We aren't here to replace the text, please. You absolutely must go read the chapter, study the MRI scans, look at the pathology slides. You cannot learn surgery purely by ear.
Exactly. But what we can do is provide the cognitive scaffolding. We want to give you the interpretation, the anchors, and the aha moments that make the dry details stick.
We want to take you from just rote memorization to actually understanding the mechanics of what's going on inside the skull.
It's high-yield revision meets a coffee shop chat. We're going to cover the pressure cooker environment of the brain, the invaders-like infection, the plumbing disasters of vascular surgery.
And the space occupiers, the tumors. We'll get into the little ones with pediatric neurosurgery, and then the really cool stuff.
The wiring, functional neurosurgery. And we'll wrap up with some surprisingly heavy ethical concepts at the end.
It's a beat journey.
It is. So grab your coffee, maybe put on a helmet just in case, and let's get into the skull.
Let's do it.
We have to start with the fundamental physics of the head. This is section 1 of our outline, which I like to call the pressure cooker. The text opens with intracranial pressure, or ICP, and hydrocephalus.
Right. And the governing concept here is the Monroe-Kelly doctrine. Now, that sounds like a dry piece of history, but the concept is beautifully, terrifyingly simple. It's the closed box theory.
Meaning the skull is the box.
And it is a rigid box. It does not stretch. Inside this fixed volume, you have exactly 3 components.
Yeah.
Brain tissue, blood, and cerebrospinal fluid, or CSF.
That's it? Just those 3?
And the math is unforgiving. If the volume of one of those things goes up, say a tumor grows, or you bleed into the brain, the pressure must rise. Unless one of the other 2 components, well, exits the building to compensate.
It's a zero-sum game.
Precisely. Initially, the body tries to compensate. It squeezes out some venous blood, or it displaces some CSF down into the spinal column. But eventually, you run out of room. You hit the knee of the compliance curve.
And what happens then?
Once you hit that point, even a tiny increase in volume causes a massive exponential spike in pressure. The system just can't cope anymore.
So, for the medical student or the trainee listening, how do you spot this before you've even looked at a scan? What is a patient actually telling you? What are you listening for?
You have to ask the right questions to hunt for the high-pressure headache. This isn't your average tension headache from staring at a screen all day.
No.
This headache has a specific signature. It is classically worse in the morning.
Why the morning? You'd think resting would help.
It's basic physiology. When you sleep, your respiration slows down slightly and your CO2 levels rise. Carbon dioxide is a potent vasodilator in the brain.
So it opens up the blood vessels.
It blows them wide open. More blood volume in that closed box equals more pressure. So the patient wakes up feeling like their head is about to burst.
That is a fantastic anchor. CO2 equals vasodilation. What else triggers it?
Anything that increases intrathoracic pressure, the pressure in your chest. Coughing, sneezing, straining on the toilet, bending over to tie your shoelaces.
The Valsalva maneuver.
All variations of it. They physically block the venous blood from draining out of the head, backing it up in the skull. Instant pressure spike.
Okay, so morning headache, worse with bending or coughing.
Yeah.
Let's contrast that immediately so the listeners have a comparison. What does a low-pressure headache look like?
The polar opposite. This typically happens after a lumbar puncture or dural tear where CSF is leaking out. The brain literally loses its buoyancy and sort of sags inside the skull.
Ouch.
The patient feels terrible when they stand up. Gravity pulls the brain down on pain-sensitive structures. But if they lie flat, the pain vanishes.
High pressure hates lying down. Low pressure hates standing up. Crystal clear. Now let's look at the eyes. Baily and Love puts a huge emphasis on visual symptoms in neurosurgery.
The eyes are the dashboard for the brain's pressure. You might see blurring, you often see diplopia, double vision.
Is that random, or is there a specific culprit?
It's usually the sixth cranial nerve, the abducens. It controls the lateral rectus muscle, which pulls the eye outward.
And why that one?
It has a very long, tortuous course through the skull. When the brain swells, that nerve gets stretched. It's the first to go down. The patient can't look outward, so they see two images side by side.
And if we grab the ophthalmoscope and look into the back of the eye?
You're looking for papilledema swelling of the optic disc.
Yep.
But here is the critical aha moment for your exams in your clinical practice. Papilledema is a lagging indicator.
It takes time to show up.
It takes 24 to 48 hours to develop. If a patient comes in after a car crash with a massive bleed, they won't have papilledema yet, even if their pressure is sky high.
That is a life-saving distinction. Don't be reassured by a normal eye exam in an acute emergency. Now, we said the skull is a rigid box, but that's not strictly true for everyone, right? What about infants?
Right. Good point. In babies, the sutures, the joints between the skull bones, haven't fused yet. If the pressure goes up, the head physically gets bigger.
The box can expand a little.
It can. The circumference expands. You'll feel a bulging fontanelle, the soft spot on top, and you see a sign called sunsetting.
Describe that for us. It sounds poetic, but I know in this context it's pathological.
It's part of Perronneau syndrome. The pressure pushes on the dorsal midbrain, specifically the center that controls upward gaze. The baby loses the ability to look up. Their eyes are driven downward, leaving the iris looking like a setting sun over the lower eyelid.
That is a haunting image, but one you won't forget. Let's get technical for a minute. If we actually place a monitor into the brain parenchyma, we see a waveform on the screen. It's not a flat line.
No, it's pulsatile. And for the high-level trainee, understanding the shape of this wave is crucial. You see three distinct peaks: P1, P2, and P3.
Break them down for us.
P1 is the percussion wave. That's the arterial pulse, the heartbeat hammering into the brain. P2 is the tidal wave. This represents the brain's compliance or stiffness. P3 is the dicrotic or venous wave.
Which one is the warning light?
P2. In a healthy, squishy brain, P1 is the tallest. It takes the hit. But as the brain swells and becomes stiff, as it runs out of space, that P2 wave starts to rise. When P2 becomes taller than P1, the brain has lost compliance. That is a red alert. The closed box is full.
P2 higher than P1 equals danger. Got it. Let's shift to the fluid itself. Hydrocephalus. Literally water on the brain.
Yeah, it's a plumbing failure. You produce about 500 milliliters of CSF a day in the choroid plexus. It flows through the ventricles and gets reabsorbed into the blood. Hydrocephalus is a backup in that system.
And the text makes a massive distinction between two types: obstructive and communicating. Why does this matter so much?
Because mixing them up can kill the patient.
Okay, that's a good reason. Let's start with obstructive.
Also called non-communicating. Think of a dam in a river. There's a physical block, a tumor, a fist, or a narrowing at the aqueduct of Sylvius. Fluid is made, but it can't escape the ventricles. They just swell up like balloons.
And communicating.
There is no dam. The river flows freely out of the ventricles, but the drainage field, the arachnoid villi, is clogged. This often happens after meningitis or a bleed. The proteins and debris just gum up the sieve. The fluid can't get back into the blood.
Right. So here is a check-in question for the listener. Pause and really think about this. You have a patient with hydrocephalus. Why are we absolutely terrified of doing a lumbar puncture in LP if it's obstructive, but we might actually do it if it's communicating?
The answer is physics. It's all about pressure gradients. If you have a dam obstructive hydrocephalus, the pressure in the head is massive. If you put a needle in the spine below the block and drain fluid, you drop the pressure in the spine effectively to zero.
You create a vacuum almost.
You create a pressure gradient, high in the head, low in the spine, and the brain moves.
Downhill.
It gets sucked down toward the low pressure. It herniates through the foramen magnum at the base of the skull. This is called cunning. It crushes the brainstem, the breathing centers, and the patient dies.
So, rule number 1, rule out obstruction with a scan before you even think about tapping the spine.
Absolutely. However, if it is communicating hydrocephalus, where the whole system is pressurized equally, an LP is actually therapeutic. You drain the excess fluid to lower the pressure.
Okay. Before we leave the plumbing, let's touch on 2 specific syndromes mentioned in the text. One usually involves the elderly, and one typically involves young women.
You're thinking of normal pressure hydrocephalus, or NPH, and idiopathic intracranial hypertension, IIH.
Let's do NPH first. This is the elderly patient who seems to be developing dementia, but there's a twist.
It is one of the few reversible causes of dementia. The mnemonic anchor here is wet, wobbly, and wacky.
Unpack that triad.
Wet refers to urinary incontinence. Wobbly is a gait disturbance. They walk with a wide base, a sort of magnetic gait like their feet are glued to the floor. And wacky is the cognitive decline.
So if you see this triad...
Don't just write it off as Alzheimer's. Get a scan. It might be NPH. A shunt can reverse it.
Now, the other end of the spectrum, IIH. Let's build a fictional case study here. Meet Sarah. She's 26, she's slightly overweight, and she comes into the ER complaining of severe headaches, and her vision is getting blurry.
Right. So you do a CT scan, expecting to see a tumor causing that pressure. But the scan is normal, no mass, no bleed. But her symptoms scream pressure.
So because the scan is clear of masses, it's safe to do a lumbar puncture.
Yes. And when you measure the opening pressure, it is sky high. That is IIH. It used to be called benign intracranial hypertension, but we stopped saying that.
Because going blind is certainly not benign.
Exactly.
How do we treat Sarah?
Weight loss is remarkably effective. It lowers abdominal and venous pressure. Medicinally, we use acetazolamide to decrease CSF production. If her vision is threatened, we have to operate either shunt or fenestrating the optic nerve sheath to save the eye.
Speaking of operating, let's talk hardware, EVDs and shunts.
In an emergency, you need an EVD, an external ventricular drain. You drill a hole and pass a catheter straight into the ventricle to let the fluid drip out into a bag. It's a release valve.
Where do you drill? The text is very specific about the anatomy.
Kucher's point.
Mm-hmm.
You need to verify this every time. It is 11 centimeters back from the nasion, so the bridge of the nose, and 3 centimeters lateral to the midline.
Why 3 centimeters?
To stay off the midline where the big venous sinus lives, you don't want to drill into a major vein. And to avoid the motor strip on the cortex, you aim perpendicular to the skull.
And for a permanent fix, we use a VP shunt ventriculoperitoneal. It runs from the head, under the skin, down to the belly.
But be warned, shunts are the bane of a neurosurgeon's existence. They block, they get infected, they disconnect, they overdrain. If a patient with a shunt has a headache, assume the shunt is broken until proven otherwise.
A high index of suspicion. Okay, moving on to section 2. The invaders. Infection.
Right. The brain is usually a sterile fortress. When bacteria get in, it's a disaster. We are talking meningitis, abscesses, and empyemas.
Baily and Love highlights post-traumatic meningitis specifically. How does that differ from, say, the college student who gets sick in a dorm?
The context is usually a skull-base fracture. If you crack the cribriform plate behind the nose or the temporal bone by the ear, you create a doorway for bacteria.
A direct line in.
And the scary part is that post-traumatic meningitis can be insidious. It's not always the explosive fever and stiff neck. It can be a slow, creeping deterioration. You have to be hypervigilant in trauma patients with CSS leaks.
Now let's look at the focal infections. Abscesses. This is a collection of pus in the brain.
Yep. On a CT scan, it looks like a ring. A dark center, which is the pus, surrounded by a bright white rim in the capsule.
The problem is a very aggressive brain tumor, a glioblastoma, also looks like a ring with a necrotic center.
Exactly. So you're staring at a ring on the screen. Is it cancer or is it an abscess? How do you tell without cutting it out?
What's the trick?
You use a special MRI sequence called diffusion-weighted imaging, or DWI.
How does the physics work there?
DWI measures the movement of water molecules.
Mm-hmm.
In an abscess, the pus is thick, viscous, full of cellular debris. Water cannot move freely. It shows restricted diffusion.
So it lights up.
It lights up bright white on the DWI sequence. A tumor usually allows water to move more freely so it doesn't light up as much. That's your discriminator.
Bright on DWI equals pus. That is a high-yield nugget. Now tell me about Pott's puffy tumor. It sounds Victorian.
It was described by Percival Pott. It's a complication of frontal sinusitis. The infection eats through the frontal bone osteomyelitis. You get a boggy, doughy swelling on the patient's forehead.
So it looks like a bump on the head, but it's actually pus oozing through the bone.
Exactly. And if it's oozing outward under the skin, it's almost certainly oozing inward too. There's usually a subdural empyema underneath.
Which is an emergency.
A huge surgical emergency because it causes septic thrombosis of the cortical veins. It causes strokes. You have to drain the pus and remove the infected bone.
Before we leave infection, a quick nod to tuberculosis.
TB, the great mimic. It can cause masses called tuberculomas, or a thick basal meningitis that chokes the cranial nerves. The lab clue is in the CSF. Bacterial meningitis has neutrophils, polymorphs. TB has lymphocytes. And the glucose in the CSF will be very, very low.
Good distinction. All right, section 3. The plumbing issues. Vascular neurosurgery.
This is high-stakes territory. We are talking about aneurysms and the dreaded subarachnoid hemorrhage, or SAH.
The symptom here is legendary. The thunderclap headache.
Patients describe it vividly. I was hit on the back of the head with a baseball bat. It peaks in intensity instantly. Unlike a migraine that builds up over minutes or hours, this is 0 to 100 in a second.
What has happened physically?
Usually an aneurysm, a blister on a blood vessel at one of the branch points in the circle of Willis, has popped. Blood blasts into the subarachnoid space at arterial pressure.
So the patient arrives with this story. What is the diagnostic flowchart?
Step 1. CT brain. In the first 12 hours, it is 98% sensitive. You see the white blood filling the star-shaped cisterns at the base of the brain.
But what if the CT is negative? The headache was 8 hours ago, the scan looks clear. Do we send them home with painkillers?
Absolutely not. That 2% miss rate is unacceptable for a fatal disease. You must wait. This is the 12-hour rule. You wait until 12 hours have passed since the headache started, and then you do a lumbar puncture.
Wait, why not tap immediately?
We're looking for xanthochromia. This is a yellow pigment. When red blood cells spill into the CSF, they break down into bilirubin. It takes about 12 hours for that chemical breakdown to happen in vivo.
So if you tap too early?
The blood cells might be there, but you won't know if they are from the bleed or if you just nicked a vessel with your needle, a traumatic tap. If the fluid is yellow, that proves the blood was there before you put the needle in.
That is a crucial logic chain. Okay, diagnosis confirmed, aneurysm has ruptured. What are the killers we need to watch out for now?
There are 3 waves of danger. 1, the rebleed. The clot sealing the aneurysm is fragile. If they spike their blood pressure, it pops again. Mortality is 50%.
50%, wow.
2, hydrocephalus. The blood clogs the arachnoid villi, communicating hydrocephalus. And 3, vasospasm. This is the tricky one.
This is the delayed ischemic neurological deficit, or DIND.
Right, it happens 3 to 10 days later. The breakdown products of the blood irritate the outside of the blood vessels. The vessels spasm, they clamp down. This starves parts of the brain of oxygen, causing strokes after the patient seemed to be stabilizing.
How do we fight vasospasm?
We give a calcium channel blocker called nimodipine, and we keep the patient well hydrated to maintain blood flow. Euvolemia is key.
Let's pretend we have a case study here. A 45-year-old weightlifter collapses at the gym. Thunderclap headache. CT shows the bleed. How do you fix the aneurysm itself?
You have to secure it so it doesn't bleed again. You have 2 main options, coiling or clipping.
Clipping is the old school way.
It's the classic open surgery. You perform a craniotomy, split the brain fissures, find the aneurysm neck, and put a titanium clothespin across it.
And coiling.
That's endovascular. You go up through the femoral artery in the groin, navigate wires all the way into the brain, and stuff the aneurysm sac with platinum coils.
Like packing a cavity.
Exactly. It causes the blood inside the aneurysm to clot off, sealing it from the inside. Coiling is generally preferred now based on the ISAT trial data, but some aneurysms are the wrong shape and need a clip.
One distinct metabolic weirdness with these patients, their sodium drops.
Yes, cerebral salt wasting. The injured brain releases peptides that tell the kidneys to dump sodium in water. The patient gets hyponatremic and dehydrated.
And it looks like SIADH, but it's not.
It looks like it, but the treatment is the opposite. You have to give them salt and fluid, not restricted, a critical distinction.
We should also briefly mention other vascular nasties, AVMs and cavernomas.
An AVM, arteriovenous malformation, is a high-pressure tangle of vessels, arteries flowing directly into veins without a capillary bed. It looks like a bag of worms. High risk of bleeding.
And a cavernoma.
A cavernoma is a cluster of low-pressure vessels. Looks like popcorn on an MRI.
Moving to section 4, the space occupiers, brain tumors.
Let's start with a reality check. If you see a brain tumor on a scan, statistically, it is not a primary brain tumor.
What is a tourist?
It's a metastasis. Lung, breast, melanoma, kidney, colon. Mets outnumber primary brain tumors significantly. Always look for the primary source.
But focusing on the primary brain tumors, the gliomas, these come from the glial cells that glue the brain.
We grade them I to bad. Grade Widthel is the glioblastoma, the GBM. It is an aggressive, devastating tumor. But Baily and Love emphasizes the molecular evolution. We don't just look at shapes under a microscope anymore. We look at genes.
What is the big gene to know?
IDH, isocitrate dehydrogenase.
And this is counterintuitive. Usually a mutation is bad.
Right. But here, if you have the IDH mutation, it is good news. IDH mutant gliomas respond better to treatment and have longer survival. If you are IDH wild type, that means your tumor is wild, aggressive, and behaves like a glioblastoma.
Wild type equals wild bad. Mutant equals mild or better. That's the anchor. Now tell me about the pink drink. This sounds like sci-fi.
It is incredible tech. It's called 5-ALA. The patient drinks the solution a few hours before surgery. The chemical is absorbed by the body, but high-grade tumor cells process it into a fluorescent compound.
So when you open the skull,
You switch the microscope light to a BLEF filter, and the tumor glows bright pink. Normal brain looks blue or dark. Gliomas infiltrate the brain like roots in soil. It's very hard to see the edge with the naked eye. The fluorescence guides the surgeon's knife. It's amazing.
let's switch to the friendly tumor, the meningioma.
Arises from the dura, the covering of the brain. Usually benign, slow-growing. On MRI, you see the dural tail, the tumor tapering off along the skull.
If it's benign, do we always operate?
No, absolutely not. If it's small, asymptomatic, and found incidentally in an elderly patient, we leave it alone. We scan it next year. The adage is die with it, not of it.
Now, pituitary tumors, these are all about location, location, location.
The pituitary gland sits right below the optic chiasm, the place where the optic nerves cross.
So if a tumor grows upward, it presses on the cross point.
And because of the way the fibers cross, this knocks out the vision coming from the sides. You get bitemporal hemianopia, tunnel vision.
So if a patient keeps bumping into door frames with their shoulders or didn't see a car coming from the side,
Check their pituitary. These tumors also secrete hormones. Prolactinomas cause milk production. Growth hormone tumors cause acromegaly, big hands, big jaw. ACTH tumors cause Cushing's disease.
there is a surgical emergency here too, pituitary apoplexy.
This is when the tumor outgrows its blood supply and bleeds into itself. The pituitary expands rapidly inside its tight bony saddle, the sella.
It's just symptoms.
Sudden headache, sudden blindness from compression of the chiasm, and critically sudden cardiovascular collapse.
Wait, collapse?
The pituitary stops making ACTH, so your cortisol drops to zero. You go into Addisonian crisis. You need stress dose steroids immediately to save their life, then surgery to save their sight.
One last tumor, the vestibular schwannoma, or acoustic neuroma.
This grows on the vestibular nerve in the cerebellopontine angle, the CP angle.
What does the patient notice?
Hearing loss in one ear, tinnitus, balance issues. The surgery is tricky because the facial nerve is often draped right over the tumor. The risk is facial palsy, a drooping face.
Section 5, the little ones, pediatric neurosurgery.
The geography changes in kids. In adults, most tumors are in the top half of the brain, the supratentorial compartment. In kids, most are in the bottom half, the posterior fossa, infradentorial.
So we see medulloblastomas and pilocytic astrocytomas in the cerebellum.
And because the posterior fossa is tight and contains the fluid drainage pathways, these kids often present early with hydrocephalus, vomiting, and a big head before they get wobbly.
Let's talk about head shapes. Craniosynostosis.
We mentioned sutures earlier. The skull grows perpendicular to the suture line. If a suture fuses too early, the skull can't grow in that direction. It has to compensate by growing parallel to the fused suture.
Let's visualize the boats and triangles.
If the sagittal suture, the one running down the middle front to back, fuses, the head can't grow wide, so it grows incredibly long and narrow. It looks like a boat. That is scaphocephaly. Scapho means skiff or boat.
And if the coronal sutures running ear to ear fuse,
The forehead can't gray forward, the head gets short and wide. That is brachycephaly.
and the metopic suture right down the middle of the forehead.
You get a sharp, triangular forehead, trigonocephaly.
What about neural tube defects? Spina bifida.
This is a failure of the stein to close in the womb. It ranges from spina bifida occulta, just a hairy patch on the back, to myelomeningocele, where the spinal cord is actually exposed in a sac on the baby's back.
And the prevention is nutritional.
Folate. Folic acid supplementation prior to conception and in early pregnancy has decimated the incidence of this disease. It's a true public health triumph.
Brief mention of the Chiari malformations. These often go with spina bifida.
Chiari is about the hindbrain slipping down. Chiari sancta is the cerebellar tonsils descending into the foramen magnum. It causes cough headaches in young adults. Chiari II is more severe, usually associated with spina bifida, where the vermis and tonsils act like a cork.
Section 6, the wiring. Functional neurosurgery. This is where we stop cutting out lumps and start tuning circuits.
It's the frontier. Take epilepsy. If drugs don't work, we can sometimes cut out the spark plug, causing the seizures.
The temporal lobe is a common target.
Yes, mesial temporal sclerosis scarring of the hippocampus. But wait, the temporal lobe is also where you store memories and process language. You can't just hack it out.
How do you check if it's safe?
The WADA test. It's fascinating. You inject a sedative called sodium amytal into one carotid artery. It puts exactly half the brain to sleep for a few minutes.
So the patient is half awake.
Yes, and you ask them to speak and remember things. If they stop talking, you know the sleeping side is the dominant side for language. If they keep chatting, The awake side is doing the work. It tells you you can safely resect.
What if you can't cut it out?
You could use a VNS vagal nerve stimulator. It's like a pacemaker for the brain, attached to the vagus nerve in the neck. It sends pulses to dampen down the seizures.
Then there's movement disorders. Parkinson's.
We used to burn holes in the brain lesioning. Now we use DBS deep brain stimulation. We sink electrodes with millimetric precision into the subthalamic nucleus.
So it's not destructive.
No, it's adjustable and reversible. It's like a pacemaker for the brain circuits. We jam the abnormal signals that cause the tremor and the rigidity. We can tune the voltage with a tablet to optimize the patient's movement.
Finally, pain. Trigeminal neuralgia. The suicide disease.
The pain is electric, lancinating shocks in the face, triggered by a breeze or brushing teeth. It's truly awful.
What's the cause?
Usually a normal blood vessel loop is beating against the root of the trigeminal nerve, pulsating, thump, thump, thump. It wears away the insulation, the myelin, and causes a short circuit.
And the surgery is a mechanical separation.
Microvascular decompression, or MVD. You open the skull, find the nerve, lift the artery off it, and tuck a tiny piece of Teflon felt between them.
A Teflon pillow.
A Teflon pillow. It works instantly. The patient wakes up pain-free. It is one of the most gratifying operations in surgery.
We've reached the final section. Section 7. Practical and ethical.
We have to mention CJD Creutzfeldt-Jakob disease. It's a prion disease. Prions are misfolded proteins that convince other proteins to misfold.
Why is this a surgical nightmare?
Because you can't kill them easily. Normal autoclaving, the steam cleaning of instruments, doesn't destroy prions. If you operate on a patient with CJD, those instruments are theoretically contaminated forever. You usually have to destroy the kit or use very specific chemical protocols.
And finally, the heaviest topic of all, brainstem death.
This is where neurosurgery meets the legal definition of death. It is essential for organ donation. The concept is that the brainstem, the generator of consciousness and breathing, is irreversibly destroyed. The heart is beating, but the person is gone.
The testing is incredibly rigorous.
It has to be. You must exclude reversibles like hypothermia or drugs. Then you test the reflexes. Pupils fixed. No corneal reflex, no gag, no cough.
And the final test, the apnea test.
You take them off a ventilator while still supplying oxygen down the tube so they don't get hypoxic. You let their CO2 rise. In living brainstem, high CO2 is the ultimate drive to breathe. The body will gasp.
And if it doesn't?
If the CO2 rises to critical levels and the patient makes no effort to breathe, the respiratory center is dead. The diagnosis is confirmed.
It is a profound responsibility to sign that form.
It is. It's the intersection of physiology, law, and philosophy.
We have covered some serious ground today, from the pressure mechanics of the closed box to the glowing pink tumors and the Teflon pillows.
If there's a big takeaway, it's that neurosurgery has evolved. We moved from simply relieving pressure trepanning to removing masses, and now to modulating function. The 30th edition of Baily in Love will likely be full of gene therapies and brain-computer interfaces.
For the listener, don't just memorize the list of tumors. Visualize the plumbing, understand the waveforms, remember why the morning headache happens.
Use this conversation as the skeleton. Now go read the chapter and put the meat on the bones. Look at those scans.
Thanks for diving deep with us. Keep your synapses firing, and we'll catch you on the next one.